Ladies and gentlemen, good morning. And I am speaking to you from India. The webinar, of course, is being conducted from Ras Al Khaimah in the UAE. Now, this morning, I got a WhatsApp message. And surprisingly, the message was from a random group, but it was about diabetes, and therefore I cannot verify its contents. But I can tell you this, it was interesting. It said that excess sugar in the blood is called diabetes. That's what it said. And of course, that is reasonably true, and our speaker will confirm this, I'm sure. And then it goes on to say that excess sugar in the brain could be related to ADHD, and in adults it could be connected with dementia. It talks about sugar or excess sugar in the blood or diabetes, and it talks about glaucoma. It says relevant to the teeth, we talk about cavities, and then the skin, it talks about wrinkles, and in sleep it says insomnia. Just look at the vast range of connectivity with excess blood sugar or diabetes and the human system. It says that cancer cells basically feed on sugar. And it says it is 8 times more addictive than cancer. And then it goes on to talk about 8 times more addictive than cocaine. And then it goes on to say that you can correlate excess sugar and osteoporosis. Excess sugar could cause obesity in the feet. There is a connectivity with ulcers, and in the nerves, neuropathy, and in the kidney, renal diseases. And all this come out of a message that I got this morning with through WhatsApp. And so I am absolutely delighted to be able to convey this information to a knowledgeable individual who will hopefully tell us whether there is any truth in this under the topic of nuances of diabetes. Friends, it is my great pleasure and privilege to introduce today's speaker. Our speaker is Dr. Slavica, who I must tell you is a colleague in the RAK hospitals. I'm quite sure that we will have Dr. Slavica's profile put up while I am speaking. Nevertheless, Dr. Slavica earned her medical degree in 1992 from the University of Belgrade through the Faculty of Medicine in Serbia. She has worked across different hospitals in the Middle East and in Europe, Serbia in particular, and has dealt with chronic disease in its entirety. She has organized CMEs through her favorite activity, if I may put it like that, the virtual hospital and she has conducted these CMEs in Serbia, Bosnia, Bulgaria, and Albania. And more important, she is the author and organizer of the virtual hospital simulator, referred to as in media, for doctors required by law, which is accredited by and certified by the Serbian health authorities. And this has happened way back from 2010 and continues. The in media simulator is used for teaching at several German universities, such as the University of Freiburg, the University of Leipzig, the University of schools. This is remarkable. This is remarkable. And it also is utilized for the Medical Academy for the German armed forces. Dr. Slavica speaks several languages: Serbian, Croatian, Bulgarian, and Russian. But I would request Dr. Slavica to speak to us in English this time. Ladies and gentlemen, friends, my great privilege and honor to introduce a friend, a colleague, and a fellow medical professional, Dr. Slavica.
Good morning. Thank you for this inspiring impressions and inviting me to be a part of now I can say traditional diabetes challenge. And as you mentioned at the beginning, talking about diabetes, introducing all the parameters and managements and everything that we know about it is the most important, the education of our patients. So I'm privileged now to talk about how we are managing diabetes. Everything that you mentioned at the beginning are the practically complications of high sugar level. So I would like to share my slides with you. And to start from the beginning. Just a second. I have some small technical issues.
Ma'am, there is a button on the bottom. Yeah.
Yes.
No, slide only you can.
I will.
Yes, your slide is now out of the screen.
Yes.
Unshaded.
Is it open?
No. Earlier it was, now
I
it
will
is
ask
closed.
for just 1 moment. I will open it.
Yeah, sure. Ma'am, if you find difficulty, can we share your slide? So you can ask for the second slide and third slide like that. If you find difficulty. Yes, ma'am. We can see now. Ma'am, you have to unmute.
Yes, yes. Sorry for
Yeah.
this technical
No
issues.
issue. No issue.
As I told, and we started with the definition, what is diabetes? Of course, it is a chronic disease that requires long-term medical attention. It is, as you mentioned at the beginning, a multiple dysfunction that are characterized by high sugar level. And that high sugar level is coming from the combination of either that inadequate insulin secretion or there is a resistance to existing insulin, or there is excess or inappropriate glucagon secretion. What are the symptoms that the patients are coming with in our clinics? This is like a frequent going to washroom or polyuria. The patients are drinking much more water or fluids. They have excessive hunger. Even though they're eating so much, they could notice they have a weight loss. Sometimes they're complaining about some changes in the vision, or they will report some different strange feelings in their legs or arms. Some of them will come with the frequent yeast infections in genital urinary region. To diagnose diabetes, we need to have some laboratory parameters. The patient will come with the typical symptoms, but we need to prove it with some laboratory analysis. We will have either the fasting blood glucose level, 126 milligram per deciliter and higher, or glucose more than 200 or higher after 2 hours of glucose tolerance test, or random blood glucose will be higher than 200. Two of those could be a very important sign that it is a diabetes mellitus. Regarding the accumulated or how the patient knows that 3-month sugar, the levels above 6.5 are significant and we can say connected to diabetes mellitus. So 2 of those parameters with the typical clinical findings, we can say that the patient is suffering of diabetes mellitus. There are 2 forms of diabetes mellitus that the patient is from the beginning insulin dependent. That means the production is low and we need to give insulin from the beginning. It is mostly happening in the younger patients, and a long time they are not aware of what is going on. They will see that they're losing weight, they have fatigue, tiredness, and all those symptoms that I mentioned before. Or simply they will come severely ill, dehydrated with diabetic ketoacidosis for the first time. The other, which I would like to pay more attention today, is non-insulin dependent diabetes mellitus. As we know, as a type 2 diabetes mellitus, and we can treat in different ways, and there are multiple combinations, so that I would like to talk about. What are the goals in the management of diabetes? So first of all, we need to make a patient symptom-free so that he will be better, comfortable, without all those issues that brought him to our hospital or clinics. So he will not go so frequently to urinate, he will not have polydipsia, excessive thirst and hunger, and he will not have a weight loss. But the most important for the treatment of diabetes mellitus is to prevent and to reduce complications of the diabetes. Those complications could affect microvascular system and mostly eye and kidneys, And we are achieving that by strict control of glucose level and, of course, blood pressure. Microvascular or macrovascular complications are affecting heart, brain, peripheral system. So all those coronary, cerebrovascular, and peripheral arteries could be affected. And that reduction of the risk we can achieve by controlling glucose level, and then, of course, lipids level, blood pressure, and the most important is the smoking cessation. Metabolic and neurological complication could be controlled and the risk reduced by controlling glucose level. Of course, when we see our patients and we do a proper evaluation, together we need to make our targets for the glucose level. And this should be really individual. It depends on the comorbidities, the patient age, patient's activities. So this should be individual. During our journey with our patients, in that process of keeping everything under control, we have established some rules, what we should check and how often we need to check to be aware that there is no complication that are appearing. So commonly, what we would suggest is that accumulated or HbA1c sugar level should be checked between 3 to 6 months. Yearly, patients should see our colleagues ophthalmologists to check fundus, to do that dilated eye examination, and to rule out any changes on those microvasculars on the retina. Then to check how the kidneys are functioning. Of course, we will check creatinine, urea, but annually we need to check also albumin, microalbumin levels. This should be yearly. Foot examination, as we know, this is a very common problem in our patients to have foot ulcers, should be on every visit. Then blood pressure, we need to focus on the levels of 130/80 as our target and to control it like that till 130/80. If we have a patient that lipid profile is deranged, treatment with statins, I know the most of them would like to avoid, but it is really recommended if the LDL or the low density lipoprotein cholesterol is high, we need to include statins in the treatment. What about our patients? So they have to be involved. We are teaching them to be involved. And the self-monitoring of glucose level is an important part of that. So if the patient is on insulin therapy, if he has insulin-dependent diabetes and is using insulin frequently, we are recommending to check glucose level before meals, occasionally after meals, before exercise. For the patients that mostly have a type 2 diabetes and they are not on insulin therapy or they are getting only once a day, they should do some self-monitoring of glucose level. When we are advising to adjust either food intake or physical activity, mostly if we are not satisfied with the control and we are introducing some new medications, we will ask the patient to check. Also, if he has any complaints related to a sugar level, they already know how to recognize them. They should check, make one like a diary and present it on the next visit. What is the treatment plan for management of any type of diabetes? The first, number one, is what I want to emphasize on this meeting today. That is on the part of our patients. So we have a lot of medicines that we can use in help to control the glucose level, to reduce the risk of complication. But the biggest part is on you, my friends. So that is diet and that is exercise. So there is no magic. We have medicines, but the magic, no. So we need to go together through this journey, and you need to do your part. So diet, that means low carbohydrate diet, to choose the carbohydrates that will not increase that sugar level fastly, that are not so easy to be resorbed. Exercises that will be regular, at least brisk walking for 30 minutes, any appropriate to the other medical conditions, so that we will discuss individually with the patient, are the most important. So we need to insist on that, and that's why I'm using this option to remind my patients again. Education's, of course, fundamental part of the treatment plan, and that is what we are doing today. So we need to discuss about all of clinical findings, complications, treatments that are available, and that's why we are gathering on these kind of webinars. And when we start with the medicines, of course, metformin would be the first drug of choice. Then we can use, if we are not satisfied, we can use additional 1 or 2 oral or injectable drugs. And finally, even if they are not at the beginning insulin dependent, most of our patients will become insulinopenic. That means they will have a low level of their own insulin production. So we need to add insulin in the treatment. As I mentioned, there are several groups of oral and injectable medications that are helping us to keep the sugar level as we wanted. The first is metformin. It belongs to the group of biconids. That medicine is lowering the basal and postprandial glucose level in different several ways. So it will decrease the hepatic production of glucagon. Then it will decrease the resorption of glucose from our intestines. And of course, it will improve insulin sensitivity. Some side effects that patients are reporting are related to gastrointestinal disturbance, diarrhea. Mostly it is at the beginning of treatment, so we are advising at the beginning lower dose so that the patient can get used to it. And the new forms of medication with the slow release, the patients are accepting better, and those side effects are less. The second group are the group of sulfonylureas. They are directly stimulating pancreas and beta cells to release the insulin, and we can see the benefits, of course, if the insulin production is there. Before starting those medicines, we need to check what is the insulin production, and that we are doing by checking the C-peptide. The methylglinide derivatives, like repaglinide, are also the insulin secretagogues. That means they are stimulating the production and their acting is faster. What could be the side effects of those medicines? are taking before meals, mostly in the morning or even twice daily, they could cause sometimes hypoglycemia. So we need to inform the patients what are the signs and how to manage that at home. The next group of the medicines available and that we can use and suggest to our patients is alpha glucosidase inhibitors, and they are delaying sugar absorption from our bowels. They're not so common, and the patients are avoiding them because of one side effect, and that is flatulence. So, of course, we need to discuss with our patients how they are tolerating the medication that we prescribed, and if the side effects are really affecting the quality of life. There are other options, so we need to change our treatment. Thiazolidinediones like pioglitazone, another group, rosiglitazone, another group, important, of course, in our treatment plans. How they are acting, they will improve the sensitivity to existing insulin, but there is a requirement that insulin is present. So for that also we need to check what is the C-peptide, what is the insulin level, so that we can use those medicines. They're really having a good effect on the progression of diabetes, and the only one showing slow progression. And for that, there is a time period that we need to wait to see the maximum effect. It is 12 to 16 weeks. A side effect that makes us concerned is the weight gain and fluid retention. So in the patient that have cardiac issues or maybe a heart failure, of course, kidney issues, we cannot, and this is not the medicine that we would advise. When the patient comes to our clinic, we need to ask, is there any weight gain? We will, of course, measure the weight, and any fluid retention, any difficulties in breathing, and other laboratory parameters we need to check. Then we have another group, glucagon-like peptide 1 agonist. In that group, we have several injectables that we are giving mostly once in a week. And this is now the most popular management because of the side effect that those medicines have a very good impact on the weight control. How they are doing that? They are stimulating glucose-dependent insulin release. So when we have food and meal, they will, of course, and additionally stimulate pancreas for insulin release. They will reduce glucagon, and most important, they will slow gastric emptying. So this will make our patients feel they will lose appetite, they will not have that excessive hunger, and all those elements will result in the weight loss. Newly approved medication last year in 2022 has a dual, the two molecules combined in one injection. Glucagon-like peptide 1 and glucose-dependent insulinotropic polypeptide agonist tirzepatide, and they have both a great impact on glucose lowering and weight control. So what we are seeing now, the patients are struggling to get that as a prescription, but the rules are rules and indications, so we cannot go directly and use it only for the weight control. And of course, I'm not advising that the patients are using by themselves over-the-counter in the pharmacies without consulting the physicians, since all those medicines have some side effects. Some of them are serious. So we need to monitor that during the treatment. Like glucagon, like peptide-1 agonists, could cause some abdominal pain or even affect the pancreas function, and we can see the acute pancreatitis. The other can also cause some cancer form. At least it was seen in the preclinical trials on animals. So that's why we know what to control, what to follow during the treatment, and to be with our patients on the safe side. Another group, dipeptidyl peptidase 4 inhibitors, they prolong the action of all incretin hormones degrades. It is the weight neutral. There is an enzyme that can destroy insulin. This medicine is neutralizing that enzyme. So the insulin that we have and all other hormones are effective and active longer. The last oral medication that I want to talk about are on the level of kidneys. Those are selective sodium glucose transporter 2 inhibitors, like dapagliflozin, empagliflozin, canagliflozin. What they are doing? They are increasing urinary glucose secretion, and also they have a good impact on the blood pressure level and cardiovascular complication, because we will have less volume and the heart will not work hardly because of that. But there are also some side effects that we need to inform our patients, because urine will have plus glucose. It's prone for some often urinary infections. Sometimes the patient could come in a metabolic acidosis, even ketoacidosis. With type 2 diabetes, it is a rare complication, but we need to be aware of it because of volume depletion. The patients are losing that volume. And if we have additionally any gastrointestinal issues with vomiting, diarrhea, of course, patient could be dehydrated, and all those will affect metabolic system. And as I mentioned before, insulins, we need them. We need them in insulin-dependent diabetes mellitus, and of course, in type 2, at the beginning, non-insulin dependent diabetes mellitus. But later, most of the patient or some of the patient will have low insulin production, and that deficit we can correct only by adding insulin. So we have variety of products that could help us, and they're different in the way how we are administered them and the longevity of the action. So we have a long-acting insulins. They mostly don't have significant peak, and they are controlling and giving that stable basal serum insulin concentration, mostly with a single daily injection. But if the demands are high and the amount that we need to give is bigger, we can divide in 2 doses. Then we have ultra long acting basal insulin that has a duration up to 48 hours. So that keeps that level of insulin for a long time, very steady. And with the short acting preprandial before meal, we can keep the level stable. For lowering post-meal glucose level, sometimes the pre-mixed insulin analogs are more effective. That means we have a combination of long-acting active insulin and short-acting insulins. To lower that postprandial level, even in type 2 diabetes mellitus, glucagon-like type 1 diabetes mellitus, glucagon-like peptide 1 are also very effective. Short-acting insulin, we have different forms. We can talk to the patient and see how they are using, what they are eating, and then we will calculate what are their needs according to carbohydrates and, of course, physical activities. Even the rapid-acting inhaled insulin we have as option, and it's found and documented that it's not inferior to injectable insulins. So everything is on the table. We have many options to help our patients to control sugar level. But the most important is that the patient has one physician to follow his instruction, to report any changes that could be related either to the bad control of glucose level or possible some complications that are appearing, complications related to the main issue, and that is diabetes, or some complications that are related to medicines that we are prescribing. So that would be all from my side. If you have any questions.
Yes, there will be questions, Doc Slavica. But before that, I would like to thank you. And I would like to thank you specifically for, doctors give us medicines, and all the medicines that they give us are often so helpful and beneficial to us. But doctors rarely explain the benefits of the medicine, what the medicine does. So we take the medicine and we really don't know the effect. The outstanding feature of today's webinar was the fact that you spoke so much about medicines, but at the same time, you explained the effect of these medicines on specific aspects of our illness. And that is what was so magical about your webinar today. I want to thank you very much. Well, that thank you comes from my side, but I'm sure there are many questions. Dr. Wilku himself, being a medical professional, will of course add to those questions. And I hand over to Dr. Wilku, sir.
Thanks.
Thank you, Professor Kennedy. First of all, thank you, Dr. Slavica. It was a wonderful presentation. And every time when we hear you and experts, there are a lot of informations coming out which we miss. So this is a great opportunity.
I cannot hear you.
Are very inquisitive. Many people, when they have any information, whether they're family members or they have some chronic health issues, especially like diabetes and hypercholesteremia. So everyone goes around to get more information, consulting their physicians, consulting their friends who are suffering with them, and even the utmost guru, the internet. They search each and everything, and they start having queries, and they will be asking like this. So anyhow, many of the questions three of the participants were not unable to participate today, but they have asked a question because they were busy with some meetings. So I will take one question from the participant, Sarfraz Sheikh. My HbA1c is 5.9. My cholesterol is high, and for which I am taking Lipitor 20 mg. On routine test, my fasting glucose and after food are well within the normal limits. but HbA1c has negligible change. Do I need to start the medicine for diabetes? Anyhow, 5.9 is a pre-diabetic state, but I don't know why he's concerned. But doc, you have to clarify and suggest him.
Yes, maybe his concern is coming from the risk factors. He's calculating, okay, I have already one, and that is a high cholesterol level. And he would like to manage that HbA1c to be better. So my advice would be to go for a really strict diet for at least 3 months, and then regular exercises. That's why I made that on the first point, and the most important one, that we cannot expect the magic. We have medicines, we have everything, but if the patient is continuing to act in the same way, to choose the wrong food, and the quantity is wrong, then we will just increase and increase, and of course he will feel some side effects because of a lot of medicines. So I would not be concerned with that HbA1c 5.9 for another 3 months. And if there is no help, I would like to see what is his constitution. Is he obese? What would be the next treatment plan? Is there any insulin resistance? And then we can decide how to treat.
Yeah, true, man. That's a wonderful answer. Next question comes from Ranjit. Is there any natural way of, to improve the insulin sensitivity? This is a very common question people come around when they are consulting the doctors, and especially the lifestyle medicine and alternative medicine. So people think about this, whether they can skip medicine and improve the insulin sensitivity to control their diabetes. Ma'am, your suggestion.
So the insulin resistance is coming mostly because of obesity and overweight. And the most natural way is to reduce the weight. How they will do it, of course, with advice of nutritionists and going to regular physical activities, exercises. There are some medicines that could increase the resistance, the sensitivity, as I mentioned before. But before going for that, we need to lose that weight. That fat in the abdominal region is acting like our enemy. So whatever we do, the fat is there and it's making our problems. So we need to manage that in a different way. If you're asking about the food, the carbohydrates are our enemy, but we need them. We need them. This is our energy. We need to work. We need to talk today. We are using it only not for physical, but for a mental activity. But how much and which type? It has not to be simple carbohydrates like sweets that will increase sugar fastly in a minute, and we are starting to produce insulin a lot, and then we are hungry again and we are eating more. So there is a circle. So it has to be carbohydrates, the grains, the whole grains. If you're eating bread, if you're eating rice, it has to be that integral, that it is making a problem to our bowels to resolve. It will take time. It will not go fastly in 20 minutes or something like that.
Yeah, ma'am. Recently, in last 2-3 days, Ministry of Health around UAE, so all ministries, MOHAP also. MOHAP have initiated one diabetes management program. So they were initiating this program across UAE, and they are advocating people, those who are pre-diabetic or obese or those who are diabetic, they can go to any health clinics and get their assessment and get the coaching from the lifestyle medicine specialists to have a good counseling for that. So this is a very good question. And recently, there are many articles also. Like the same question, Dr. Madhurima is also asking. Recent research and studies show diabetes can be reversed. What exactly is meant by reversing a diabetes?
Reversing the diabetes, we can say that the patient, when I talk about the target, what we want to achieve, especially as a HbA1c level. So you can see some differences, like 7 point, below 7 is a perfect. In the Anti-Diabetic Association, American Diabetic Association, they want to see that the HbA1c below 7. Then some physicians in USA, they would like, it's enough to have it below between 7 and 8, which I disagree. Maybe this is coming from the other aspect of treatment that is, of course, expensive. If we have a patient that we cannot easily achieve those targets, we need to introduce some more expensive medicines. And then, okay, they will accept it's okay to have it 7.8, 7.9. But with every like 1%, if it's below 7, by 25% we are reducing the retinopathy or cardiac morbidity, mortality. So it is important to have. So what we agreed that if 3 months patient is having the HbA1c below 6.5, it's remission. This is the under control. But if we have the HbA1c that is going back to 5.7 below, and it needs less and less medications, so of course we can reverse. I had a patient that he has HbA1c 11.8. And of course, I started to shoot from all the weapons that I had. But he decided to change his life. And he was on a strict diet with dietitians. And he came to me, HbA1c was 5.6, only on one oral tablet. I was so happy. And the kidney function was better. Microalbuminemia was absent normal. So we can reverse, but it takes effort from the patient side and us as someone who is guiding the patient on that journey. If there is a morbid obesity, if we cannot help, it is hard to control morbid obesity. We can even go like more drastic to offer some bariatric surgery or a balloon insertion or something like that, just to achieve the weight loss. Of course, there is a medicine for that also. And the patients know about that. And they are going to buy by themselves, even if it is so expensive. I disagree with that. Please come to us, to physicians, and we will guide you. And there are reasons for that.
Yeah, true, ma'am. And that's the reason you have said wonderfully, because diabetes can be reversed. Definitely, it can be reversed, but you have to religiously follow the protocols made by a physician, and you have to be self-disciplined. Then only you can achieve the
And
maximum
of
out of
course,
it.
it is depending on the type of diabetes. If it is
Right.
autoimmune, if it is type 1, and if it's caused by some pancreatic disease, destruction of something, in that case, it is hard to reverse, of course.
Little difficult for that. Yeah. Ma'am, there is one question which I was just telling. One of the participants who was unable to attend the program today, and her name is Preeti, and she is from Dubai, and she has asked, my blood glucose levels were very high. I was put on insulin for 6 weeks along with oral medication, and then only oral medication was prescribed as her fasting and post PP glucose levels were within the acceptable range. But her HbA1c always stays above 7.5. Now I have been prescribed to start Mounjaro once in a week. And she read in the internet that it has a fatal side effects. So she is confused what to do. So your suggestion, ma'am.
That is the medicine that was introduced on the world market for diabetes control last year, 2022, and it is really having a great impact in the sugar control. And it is a combination of those two molecules that I mentioned. Of course, that there could be, and the weight loss is a side effect, and it's for some patients a very nice side effect that they want to achieve.
They'll be happy.
What is mentioned in regarding that medicine, of course, in preclinical trials on some animals, they have noticed incidence of medullary carcinoma, thyroid carcinoma.
Yeah, yeah.
Since it is a short period of time that we have this medicine, but the molecules that is inside, we have it. We were using it before. And the side effect could be like pancreatitis, some other issues. And we haven't noticed those fatal complications. But if the doctor is prescribing, of course, he knows how to track any single sign that something wrong is going on with the medicine. That's why I'm advising, even if they want to lose weight and lose the side effect of the treatment, it should be prescribed by the doctor, and we should monitor. There are some laboratory parameters, ultrasound, and some other like a clinical signs that we can catch in the right time if there is something wrong with the medicine. Not the last one, but there are some others also that we need to follow.
Yeah, sure. Close monitoring has to be done.
Yes.
There is one question which is similar to what we have been screening a corporate yesterday. So I came across one question. This question is also very similar. Himanshu Singh is asking, I read somewhere the chronic blood pressure medication can increase the risk of diabetes. Is it true? I am just mentioning because yesterday one of the patient was diabetic and he was not taking medication for last 2 years. His intuition was if I start taking medicine, I have to take medicine lifelong and there is no cure, and it will affect a lot of other vital organs also. So even though his levels were very high, even yesterday when we checked, it was very high. But he's reluctant. He doesn't want to take medicine. He said medicines will create a lot of problems. This is similar question.
The fear with the patient is always existing regarding some medications. And of course, all of us, we would like to use them as less as possible. So that's why I'm coming back to the beginning. Diet control, even for blood pressure, low salt diet, weight loss, regular activities will help a lot. But if we cannot manage to control, we need to start with the medicines. So if the patient has a comorbidity, of course, we will choose the medicines that will not affect the other ailments. Of beta blockers sometimes could compete with the receptors for insulin, for example. But the pharma industry is, of course, going ahead, and we have selective beta blockers that will not block. So that fear sometimes is not realistic, and we should reassure our patients. The most important, we need to, even the medicines that we are giving for blood pressure, like ACE inhibitors, are very good in diabetes to postpone and control kidney function complications. So we know about that, and we are choosing the right medicines. So just find one doctor who will follow you through all the way, who will know you. The worst is I don't like what she said, then I will choose another doctor. They will go and they will search for opinion. Mostly they would like to hear that they don't need to take medicines, but that is not the truth. We will start with the lifestyle management. We will give a trial, but if it's not helping, we need to introduce some treatment.
Correct. Ma'am, there is very common confusion and people are very much concerned about this. Even Mr. Alam is asking. I always means he's following a good diet and even go to gym, but still he's not able to lose weight.
May I, Dr. Slavica, with your permission, may I answer that question?
Of course.
Oh, thank
Yes,
you,
sir.
thank you, thank you. The question asked, as I recall, is that Alam goes to the gym, but he does not lose weight. Mr. Alam, my long experience in the range of exercise, and I recall Harvard has written a book in which I was one of the editors called Exercise is Medicine. And one of the things that you need to know is that when you exercise, you lose fat, but you gain muscle. Now, when you gain muscle, as you know, muscle is heavier than fat. So effectively, many times when you exercise, you actually gain weight. So if you wish to lose weight, then dieting is one aspect that will help you along with exercise.
Yes.
But the good news about exercise is, and here is the hormonic differences between male and female, and that is that when you exercise, both male and female lose fat, but the female actually loses inches, whereas the male actually gains muscle. So they both achieve their objectives. Exercise in many ways, Mr. Alam, is a magic pill, which I'm sure Dr. Slavica will also be recommending from time to time. Thank you for your permission, Dr. Slavica. Thank you so much.
It was expected from a wellness guru like you, sir. It was well accepted, this answer.
Yes.
I think all questions are now over. So, over from my side. Professor, over to you.
Thank you. Dr. Slavica, I am so touched by the wisdom of your explanations. The question asked was, can you reverse diabetes? And you said, of course, you can reverse it, but it is a lifetime activity. And
Yes.
therefore, you need to continue with whatever your doctor advises you. And that is excellent. And then when we spoke about the fear of medication, and Dr. Wilku, in his own practical experience of thousands of individuals that he meets on an annual basis, thousands and thousands, and he gets the questions asked, and the fear of medication was the question, and you so eloquently pointed out the benefits of medication versus the fear of medication. The doctor must kindly inform, with kindness and understanding, inform the client or the patient that medicine has its own values, and we wouldn't prescribe it to you. You have nothing to fear. It will only give you benefits, minor side effects, but not to the point where it will do you damage. With that, thank you, Dr. Slavica. Thank you so much.
Thank you very much also.
Dr. Wilku, I need to thank you too, sir. All your questions are insightful, very insightful. They come from years of experience. Thank you so much for that. And I also need to thank Dr. Slavica, of course, Dr. Wilku, of course. I have to thank the team at the back end that helps us to put up these seminars, IT and the wellness team, RAK Hospital for their various facilities. And last but not least, I want to thank the several participants who sit on this program and listen to it. Your presence is the one that inspires us to continue week after week. Thank you so much. Now, I do believe that we will have another seminar sometime. Let me see. Yes, there it is on the screen. On the 13th of October, we will be having a seminar, a brand new speaker, as I see it, Dr. Adil Rizvi, who, as I recall, is a cardiac surgeon, and he will be talking to us about diabetes and heart health. And I can tell you that this is going to be an interesting program. I have sat with Dr. Rizvi often enough, and he has an insightful understanding not only of the medical and surgical aspects, but also the relevance of lifestyle change. We look forward to this on the 13th. With that, Dr. Wilku, once more, thank you so much.